very much, and I apologise, I probably wrote that, it was a bit long-winded, wasn't it? So first of all, thank you to Vicky and her partners in crime for the invitation to come and present to this meeting. I think this is a fantastic innovation. I'm, if you like, the first biology research-related talker today, or the set of the meeting, that hopefully will generate some discussions, and hopefully I'll be able to introduce you into some work we're doing. And I'm really hoping that we can bump into a few people who may be able to help us in the future. I'm going to sort of keep the science light as much as possible. I might show you a little bit of data if I can get my screen to move. There we go. But I wanted to start off with telling you a little bit about the importance of hemostasis, which is the main focus of the research in my group. Now, clearly, we take this for granted. When we cut ourselves, it's really important that we stop bleeding quickly. The consequences can be quite catastrophic. And clearly, the reason for this is that our blood system is a pressurized system. If there are breaches in that system, loss of blood very rapidly can lead to some very severe consequences. So we have a complex system that has evolved that protects us, that effectively enables the blood, which is, you can see, in fact, the lady who's just about to take my photograph took this actual photograph. It's my blood, and if you look really carefully into it, you can see the reflection of me standing there holding it, just in case you thought this was stock art. So the hemostasis system is there to enable the blood to stop flowing, if you like, to plug breaches in vessels as they occur. And clearly this has an important protective role. So the key goal here, I guess, is to repair quickly as possible without too much damage, which is a good thing. And we want to avoid bleeding. Now, it's a really interesting system. There's all sorts of really interesting elements of biology in hemostasis. But actually, that's not our main motivation for doing this. Our main motivation actually was introduced really nicely with Dimitris a while ago in one of his tables. Hopefully, most of you could recognize where we're going here. This is a coronary artery, and the inside of this coronary artery is not very well. You can tell that because it's yellow and there are these strange patches that are protruding into the blood vessel wall. These are atherosclerotic lesions, so these are effectively the consequence of all sorts of inflammatory processes that are increasingly better understood, but very hard to prevent. And what you can see here is lots of little bluish coloured cells. These are platelets, and they are recognizing the inside of this blood vessel and thinking it's damaged. They're thinking they're seeing damage. And as a consequence, they're responding in the way that they should respond to damage, and they're sticking to each other. Oops, apologies. It's going to start again. So as these cells start to stick to the area of damage, they start to build up the initiation of the process that ultimately leads to blood clotting. But the problem is this shouldn't usually happen inside blood vessels. It should happen where there are breaches in blood vessels to stop leaking. You can see the platelets, these cells are responsible for releasing a whole range of different chemical signals that further enhance this process through paracrine or autocrine effects that effectively ensure a very rapid response. And clearly, if you're bleeding, that's a good thing. But if you have lesions like these atherosclerotic lesions in your blood vessels, it's a bad thing because it can lead to thrombosis. And as Dimitri's chart showed, this is right at the top of that list of problems now and for the future. So there are sinister sides to hemostasis, and this is our motivation. You'll be familiar with heart attacks and strokes. This actually is just a visualization of how we study this in the lab. So this is mouse cremaster arterioles. We're looking at, you can see the blood flowing from top to bottom in this particular field. And you might just be able to see the accumulation of platelets on the right-hand side here. These are accumulating because we fired a laser down a microscope that causes a small amount of damage on the inside of the blood vessel. And this is effectively triggering thrombosis in a living mouse. Now, this is a complex area. Clearly, there are a whole range of different reasons why one might develop atherosclerosis or other inflammatory conditions, and a whole range of other things that I'll come back to right at the end that impact upon the hemostasis system. And of course, as we've heard already this morning, viruses can also have sinister side effects when it comes to, or sinister effects, I should say, when it comes to triggering unwanted clotting. So the hemostasis system is divided into two halves. They are sort of separable. They're studied in separate manner, although they are somewhat interconnected. And the first of these is what I'm going to focus on with you today, which is platelets. So these are very small blood cells. They're the smallest blood cells in the circulation. They're in very high quantities. And they are there really to respond to injury, as we've just seen. They are able to do this because they have receptors on the cell surface that enable them to see things that are exposed, released, produced at sites of tissue injury. And as a consequence, they are converted from these quiescent disc-shaped cells that fly around your circulation into complex aggregates. They become rapidly activated, as we've just seen in the cartoon, and form a thrombus. But then the other side of the coin is the coagulation pathways. And if anyone's ever studied these in biochemistry lessons, they will understand how complex they are. But ultimately, they lead to the formation of fibrin, which is the process that polymerizes the protein fibrin that ultimately causes the blood to turn from a liquid to a gel. And these two processes influence each other heavily. So I guess an important question is how does interfering with these processes benefit if we're thinking about preventing thrombosis? Well, we actually have a whole range of drugs that are already available that target either platelets or target the coagulation systems. There are some examples here, and I won't go through them. Many of you will be familiar with a lot of these. And they are proven to be very effective in secondary prevention. So if you already had a heart attack or a stroke, they work well in preventing this occurring again. But recent clinical trials demonstrate that they're not very effective at preventing primary thrombotic events. And therefore, the risk of taking these drugs outweighs the potential benefit. And the risk is largely comes about because interfering with drugs with a critical homeostatic system carries risk. You can reduce the activity of the clotting system as much as you like, and it may effectively reduce the risk of thrombosis. But with that, you introduce the potential of increasing the risk of bleeding. So our ideal situation is that a patient who's at risk or has had a heart attack or stroke is given these drugs, and it has an effective effect. The patient's happy, the doctor's happy. But in many cases, I apologise, that's a chocolate teapot, it's not very obvious. In many cases, it's not effective at all. And in many patients, they suffer from unwanted bleeding side effects. And so ultimately, what we'd like to be able to do is to develop therapies that are targeted towards patients more specifically. And I guess we need to ask the question, why doesn't it work as well as it could currently? And one of the main reasons for this, or potentially one of the main reasons for this, is that the way in which our blood clotting system works is somewhat variable. If I was to take blood from every person in this room and we did a series of individual tests on each of you, there will be a variety of responses. Ultimately, your blood would clot, but maybe some people's blood works better than others in this respect. So there's variability. And actually, one of the problems that this whole field has had in appreciating this is that most of the researchers like myself who are working on these types of systems work in universities. So where do we get our blood from when we study people who are studying platelets and work out how they're working? We get them from young, fit, healthy people, whereas our target audience that we're probably aiming at when it comes to drugs that treat these conditions are not, by definition, young, fit, healthy people. And that it also brings with it a degree of potential variability. So the problem at the moment is that we tend to use a one-size-fits-all process. If a patient fits particular criteria, risk factors, they may be obese, they may have family history, they may have hypertension, various boxes are ticked, and therefore they're given standard medication. And maybe that's the problem. If we were to consider someone's clotability, maybe we'd be able to target them more appropriately, and maybe this would enable us to better approach the problem of primary prevention in addition to secondary prevention. So effectively, this is, I'm preaching to the converted here, I realise, but this is the effect of effectively precision medicine. If we could take a population of individuals, do a series of tests on them, divide them into groups, and then based upon those groups, which probably tell us something about their disease risk, and enable us to decide which medication, if any, they might be given. And this is one of the things we've been thinking about. So just to introduce this, I thought I'd show you a little cartoon of how platelets work, just so that there's a little bit of science in here. So this is the inside of a blood vessel, and the blood is flowing from left to right. And here we can see the first platelet coming along in the circulation. The platelets are marginalized to the sort of the outside of the flowing column of blood because they're tiny, so the big cells push the little cells outwards. So they're right on the inside of the blood vessel wall. When damage occurs to blood vessel wall, for example, a cut or maybe the endothelial cells that line the blood vessel are eroded away, the proteins that are underneath are exposed. And in this case, we can see basically a fiber of collagen. Now, platelets have receptors for collagen and other proteins that bind to collagen. And this enables them to attach to that collagen that's exposed. They then roll along the surface on the inside of the vessel, largely because they've got lots of receptors and the interactions are weak. So they roll along and gradually slow down. Interestingly, this happens much better in the arterial circulation where the blood flows quickly, rather than in the venous circulation where it flows more slowly, which is a bit counterintuitive, which I can discuss another time if anyone's interested. But effectively what happens is the cells become tethered to the blood vessel wall. Can you see my cursor? Yeah, okay, it's a bit slow. So they become tethered to the blood vessel wall, and then they become activated. So a whole series of biochemical reactions are triggered inside the platelet that leads to one critical thing happening, and that is a receptor on the cell surface becomes sticky, and that receptor is specifically there to bind to a plasma protein called fibrinogen, and this literally glues the platelets together. And if this were a breach in the blood vessel wall, this will be plugging the hole. And then we have activation of the coagulation pathways, which leads to the formation of fibrin polymers that really consolidate this and hold it together. So this is sort of a cartoon version of what we understand. Shall I let Slavak in? Oh, well, there we go. So this is our understanding of there's a cartoon form of how hemostasis works. But what happens if we want to test this in the laboratory? What sort of really sophisticated tests do we have available in the average clinical laboratory to do this? Well, actually none, because your average clinical laboratory wouldn't do this. They would be referred to a specialist centre where they would do a test, probably designed by Gus Bourne, who unfortunately died a couple of years ago, 2 or 3 years ago. He was the sort of granddaddy of this whole field of research. Very interesting chap, a clinician and scientist who discovered many of the early aspects of platelet cell biology. He's actually the son of Max Born, who got a Nobel Prize for physics. That must be a lot of pressure if your dad got a Nobel Prize, but there we go. So he invented a technique which is still used in labs around the world now called Born aggregometry. And effectively what you do is you take some blood and you spin it down in the centrifuge at slow speed, and you obtain plasma that's got the small platelets inside, and you put these in a cuvette. They're then stirred in a cuvette to which something that would normally activate platelets is added. In this case, it could be collagen, for example. I've already mentioned that collagen activates platelets. And the suspension is stirred. Now, as the platelets that are in the suspension respond to the collagen, they start to become sticky and they stick to each other, just like they would on a blood vessel wall that I just showed you in the cartoon. And as they stick to each other, the liquid becomes much clearer. As the cells stick, it becomes much less opaque. And so effectively, if you measure the optical density of the suspension, it changes, it decreases. And this is how it's measured, the extent of the response, the speed of the response. The problem with this is it's very, very variable. It's very user dependent, whoever's doing the test. It's time consuming and it uses a lot of blood. So hardly ideal for routine use, which is probably why it's not been adopted very commonly. Another type of approach that we've tended to employ is using flow cytometry. So it's a technique to use antibodies with fluorescent markers on the surface attached to them that we can use to detect activation of platelets. And this is an approach that we've employed in a system that I'm going to introduce to you. So how does this work? Well, effectively, what we're able to do is to produce assay tests. We do this, we manufacture these in the lab, and essentially they are plates that are coated and freeze-dried with a whole range of different activators of platelets. And for each of those activators, we have a whole range of concentrations. So we're doing a full pharmacological profile, if you like, for each of the things that platelets will be activated by. So we take our blood sample. We can either do this with whole blood. More often, we would just spin the blood down and use the platelet-rich plasma that I've just mentioned. And then we feed this into a flow cytometer, which has an autoloader on it. This produces more data than we ever imagined. We got well and truly out of our depth when we first started doing this, when we realized that this is going to be a mammoth job to try and work out what's going on. However, we've been using, and I'll show you in a moment, a range of different analytical tools that the group have developed that enable us effectively to phenotype the individuals based upon their platelet function. So this is effectively how it works. We recruit our patients, or this could be any situation, I guess. We've done this with healthy cohorts. As you see, we're also doing this with patients. We perform the assay, and then what happens is a member of my lab I'll introduce in a moment has developed code that enables us to analyze this data quickly. It extracts the data from spreadsheets, plots all of the binding curves, and then extracts the relevant parameters that we found are important for comparing individuals to each other. And these effectively are the sensitivity of platelets to whatever we're stimulating them with. And this is defined as what we pharmacologists would call the EC50. So it's the midway point in this curve. And the other is the response capacity, which is basically how much the platelets respond. We can do all sorts of statistical summarizing of the data, and then using a machine learning approach, cluster this into phenotype groups. And if we look a little bit more closely, we've called this very grandly platelet phenomics analysis. Sounds very posh, doesn't it? Okay, so this gives you a little idea. We don't need to focus too much on the detail here, but this is a heat map that shows how we can look at this type of data. Along the top, we've got a whole range of different types of responses the platelets make to a whole range of different things that activate them. And the numbers going from top to bottom here are each of the individual patients or volunteers in this particular example, and these are all healthy volunteers, 150 of them. And basically, we've clustered by response. And basically, the computer, which knows nothing about the data, has asked the question, how is everybody related to everybody else? And tried to organize this in the most logical fashion. And the high response is red, blue is low response, and hopefully you'll be able to see that they do divide into nice clear groups, and this is reproducible and robust, using a range of different statistical tests we've used to test this. But you can see that there are some that are clearly high responders, like this group at the top, and some that are somewhat lower responders, this blue group 2C here. You'll notice there's a green column here. This is data that we've added afterwards. So we've measured all sorts of other things on these individuals. So we've then asked the question, where are the people with, say, for example, high BMI? And that's what's in the green column here. Underweight is very light green and obese is dark green. And hopefully you can see that there are groups within this phenotyping process in which people with high BMI are clustered. And this was our first indication that this may be a useful approach, just based on platelet function, that clusters people who have known cardiovascular disease risk factors. And this is something that sort of spurred us forward in developing this further. And you'll see on the right-hand side here, these are just the p-values for comparing a whole range of different parameters. So the really impressive one here is BMI, but we've also got cholesterol ratios and insulin sensitivity as well. So there's some interesting signals in there. For those who are sort of looking at the detail here, it's quite interesting to note that it's actually this group is the low responders, not the high responders, and that's exactly the opposite to what you'd expect. Worth bearing in mind when we're thinking about which medication you would give to each individual people. So we're able to develop distinct phenotype groups using this type of approach. The clusters are stable and reproducible, and these map onto known risk factors for cardiovascular disease. So this, we think, will be a way of stratifying patients going forward. But we need to understand how this performs in disease. We don't know, for example, how phenotype, platelet phenotype alters with specific clinical situations. I'm going to skip past this because I want to show you a picture of what we're doing. Okay, so at the moment we're in the middle of a study where we're looking at cardiovascular disease patients, specifically individuals who have ischemic heart disease, that's one group, ischemic heart disease with type 2 diabetes, that's the second, and the third group are matched controls that are recruited through the same route. And this is a collaboration with Cardiology College at the Royal Berkshire Hospital. And there are their mugshots there. So it's Charlie and Neil with Sharon, who is responsible for recruiting the patients who come in either through the angiography clinics or through CT. And we're able to identify individuals with or without ischemic heart disease. They then bleed these samples. Nalina then cycles them up the hill. Actually, no, I think sometimes there might be a bit of driving down the hill to get them, or maybe walking. But Nalina will pick up, or others will pick up the samples and bring them back to the lab. For a whole team of people who've been responsible for doing the type of analysis I've just introduced you to. So they do their own science and they produce lots of data. So this is ongoing work and very much work in progress. But what we are able to see is some initial patterns in the data. For example, the ability of an individual to respond to an antiplatelet drug seems to be related to how responsive their platelets were in the first place. That might sound kind of obvious, but it's an important first step to understand how we group individuals and understand the relationship between a phenotype group and how they respond to a particular medication. So, as I say, this is ongoing work that is developing at the moment. So we're also interested in understanding how this works. And so with colleagues at the Target Discovery Institute and others, we're looking at how variability in the control mechanisms inside platelets is able to explain what we see. One of the reasons for this is we appreciate that the sorts of tests we developed are not necessarily applicable to every clinical lab. It's really quite complicated to use this type of assay. But what we're starting to do is to use this and statistical modeling to develop simpler tests that don't actually require measuring platelet function at all. They just require measuring the amount of specific proteins in platelets. And the reason that's important is that this type of analysis, and one of the reasons why it's not readily used, particularly in clinical trials, or born aggregometry has not been used in clinical trials, is the fact that the platelets have to be analysed close to the patient or a very short time window within 3 to 4 hours. And that very much limits the application of some more complex tests in this setting. So in addition to developing analysis that is somewhat more detailed, which could apply, for example, in a clinical trials capacity, we're also thinking about how we might apply this to stratify patients using simple tests that might be more palatable in a clinical setting. So our long-term goal with this side of the work is to better understand why heart disease is more common in diabetics, to understand the mechanisms behind that, but specifically to enable us to identify particular patient groups that would enable us to treat them in particular ways. And the work that's ongoing is really aimed at looking at that. Obviously, that's just looking at ischemic heart disease, and there's a whole range of other settings where this might be important. And that's where I wanted to sort of finish up with a couple of examples of other things that we've been doing where this type of analysis could be quite important. So in the middle of this picture here is a platelet. Confusingly, it's quite red, wrong colour, but anyway. Around it, you can see here a range of different conditions with which platelets or aberrant platelet function has been associated. We've talked about thrombosis, but they're also highly involved in inflammation, and their role in inflammation is certainly involved in atherogenesis as well. Neurodegeneration, bacterial defense, bacterial infection in particular commonly triggers clotting in the circulation, viral infection, parasitic infection, and cancer. Cancer in particular is quite an interesting one. Quite often, clotting is associated with cancer. So we've applied this type of approach to a study looking at myeloma. That's work that's almost completed. As the rest of the world started working on COVID, so did we. So we've also been applying this in the area of COVID, and I'm going to show you one quick example of the science behind what we've been doing there. And an ongoing pilot study at the universities is looking at neurodegeneration and trying to understand the the similarities in biochemical and cell biological processes that occur in platelets and how these might be related to what's going on in the vasculature in the brain. Again, to look for mechanisms and new ways of treating. So if I just focus on the on this particular COVID viral infection related story. So at the beginning of the pandemic, colleagues in Amsterdam noticed a really interesting phenomenon. They were able to show, when they isolated antibodies from individuals with serious effects of COVID, that the antibodies were abnormally processed. Post-translational modification of the antibodies was a little bit different. This is all related to the fact that antibodies are glycoproteins that have complex chains of sugars attached to them. So these are depicted by the different coloured shapes that are attached to the side of this particular antibody. It seems that the glycosylation of antibodies is really important because it changes the way in which the antibodies bind to their receptors. And it's the antibody binding to the receptors that initiates the immune response, whatever that might be in whichever context. And interestingly, what this does is it makes the antibodies, in this case, the difference that was observed, which if you're interested was low fucose and high galactose. This particular change is associated with causing an increase in affinity for antibody receptors. And this, they showed, was responsible for increasing macrophage responses, inflammatory responses, damage to endothelial cells, and potentially could underlie some of this long-term chronic inflammation that occurs, acute inflammation that occurs in this particular condition. So we were interested in this because the group in Amsterdam identified the receptor or the receptors that are responsible for eliciting this on macrophages. That was interesting to us because platelets have an antibody receptor, one antibody receptor, and it was one of those receptors. So we asked the question, does this change the way that platelets respond? So I'm going to show you one piece of data, but this is how we went about doing this. With the help of Ian Jones, who's an expert on coronaviruses and works at Reading in biological sciences, he produced recombinant spike protein from the coronavirus. And then with help from Jeroen van Dennen from Amsterdam, he supplied us with antibodies from a patient, so the monoclonal antibodies that are produced effectively from a patient that have been produced in a way that modifies the glycosylation in the same way that we see in patients. And so we're able to compare control antibodies against the virus against abnormal antibodies against the virus. Then Alex, who is recently left us but was working in our group, then looked at thrombus formation under the microscope using a microfluidic type device and a confocal microscope. And this is the sort of thing we saw. So the left-hand side are some images of what we see when we look down the microscope, and on the right-hand side are these shown graphically, and I'll highlight them together. So this is effectively what we see in the red box here. That's, believe it or not, thousands of platelets have stuck to the inside of this capillary or the flow cell that we're using. Incidentally, it's coated with collagen, so it looks like the inside of a damaged vessel. This is what it looks like in blue if we use if we do this in the presence of abnormal antibodies. So you can see quite a big difference. So I should have said the wild type WT refers to the normal antibody, and the boxes at the bottom, low fucose, high galactose, refer to the abnormal antibodies. And you can see a quite dramatic difference, which is shown graphically on the right-hand side. Now, if we do this experiment in the presence of a drug that we know interferes with one of the signaling molecules within the antibody receptor pathway, we're able to reverse this. So you can see here that the abnormally high platelet response is diminished. Now, this is taking advantage of the fact that there are already drugs that are recently produced and are available in the clinic and approved for use against particular immune dysfunction, particularly in the context of ITP, immune thrombocytopenia. And we're able to reverse this hyperactivity. Interestingly, there's two other drugs on this slide, which are other drugs that we also showed are able to inhibit. But if we focus just on fostamatinib, this is a subject of a recently wrapped up clinical trial, which I don't have the data for yet, where in collaboration with Nikki Cooper at Imperial and Hammersmith Hospital, we were recruiting patients who had COVID-induced pneumonia, so they were admitted to hospital. And this was one of the arms of the clinical trial to see whether we could reduce the symptoms and reduce the occurrence of clotting that occurs in these patients. Sorry, I should have said earlier on, you probably remember that blood clots was one of the key side effects of COVID, or one of the effects of COVID, particularly in the lungs, but also in the kidneys and other organs where the microvasculature generally becomes clogged up. So we're taking this type of technology forward, along with one or two other technologies, particularly developed by my colleague Chris Jones and Al Edwards and his lab that are also here, looking at point-of-care devices that are able to measure platelet function in a much more simplified manner. But the analysis I've shown you today, we're hoping can be developed as a means to stratify patients. We need to know a lot more about how this works, how patients perform in these assays, and also how this maps onto the use of particular medications. But this could be used in clinical trials, clinical trial design, and ultimately diagnosis. I mentioned that in some contexts, we need to simplify this, and this is something we're working on. And we've had some good degree of success there, actually, in some simplified analysis that enables us to get to the answers without doing quite such complicated analysis. So I guess that fits more broadly into the idea of point-of-care type analysis that I know you're interested in. So just to finish up, I just wanted to acknowledge who paid for this. So this was partly funded by the University and Royal Berkshire Hospital in a pilot study, BHF programme grants, and the MRC for the COVID work. And I need to acknowledge the teams of people. So this is the cardiology-focused work, particularly flag up Nalina, who's been responsible, and Tanya, who've been responsible for developing the assay, and along with Zana. Alex particularly involved in a lot of the analysis, and Joe was the mastermind behind all of the computational mathematics side of things. Joe's worked with me for a number of years, and it's a really interesting interaction because she's a mathematician, and she works in the works solely with my lab, working on things related to blood clotting, and it's very much opened up the way we think about analysing data and how we might be able to exploit the sorts of things that I've shown you. And really, honestly, we went into this very naively and got overwhelmed by data, and it was only Joe that managed to save us from the sort of sinking under it all. And these are the faces that I've already mentioned, introduced them, that are associated with the COVID-focused work that we've been doing. And with that, thanks very much for your attention, and I'm more than happy to answer some questions.